Dr. Supriya Dabir Gautam, consultant VR services at Rajan Eye Care, Chennai, to give a talk on application of adaptive optics in macular surgeries.
Good morning, everybody. It's a privilege for me to be here on this podium, and I'd like to thank the organizing team and Dr. Dhanashree, Dr. Pramod Bhende for having me here this morning. I'm going to be speaking on adaptive optics in macular surgeries, a topic dear to my heart because we were some of the first ones in Bangalore to start working on this while I was there. So what adaptive optics, how did it come into ophthalmology? It was first adapted by the astrophysicists when they were looking at telescopes, using telescopes to look at distant objects. And this is how images are appear of the distant satellites and the planets without adaptive optics. And when you use telescopes which uses adaptive optics, it removes all the aberrations in the atmosphere, and you can see structures, further structures which are far away very clearly. And literally this was an image by NASA where they could literally see a woman sitting on a planet. This was a Mars rover Spirit, and of course there was a debate whether there was actually a woman or just a stone which looked like that. So that's the power of adaptive optics. And why do we need it in ophthalmology? So retinal cameras have been limited so far because the aberration correction that we can do has only been defocus, and so our resolution has been limited to the macroscopic scale. And in order to bring this to microscopic scale, it's very necessary to compensate not just for the defocus but also astigmatism and the higher order aberrations. And this is how an image looks with aberrations. And once you apply a correction to this is how clearly you can see your images. So it's a technology which we have adapted to improve the performance. And if you can compare this and SLO, where it gives us a resolution of about 15 to 20 microns, with adaptive optics, what you can see is almost at images at resolution of 2 to 4 microns, and you can see cells. So it's almost a near histology that we talk about kind of resolution, where the retinal cells are visible individually. So what are the components of an adaptive optic system? You have a wavefront sensor which measures the distortion, a corrector which compensates for this, and a control system which helps to adapt these together. And there are different kinds of AO images, and what we had was RTX1, where we had a deformable mirror which changes its shape to correct for these aberrations in the wavefront. What all can it do? It can detect early signs of pathology, look for short-term progression, and help us also see the effect of treatment. Like now we are having gene therapy, drug therapies, lots of maybe yellow laser, see the effect of this. So before it's actually visible as a line on the OCT, you're looking for early structural changes in different pathology. This is how a mosaic looks. This is 40 images which are acquired in about 4 seconds. And then the machine itself has software where once you choose your region of interest, it gives you various maps, the density, the spacing, and the Voronoi analysis. So we have done early studies to see how the variation in the cone packing density is in emmetropes, how it varies with increased axial length, how the cones get dispersed, and this is in myopes. And then we've looked at the structure function correlation in normal patients using adaptive optics with microperimetry. Now, this is how a macular hole looks in adaptive optics, and you can measure the dimensions, the diameter of the macular hole correctly. And in a lot of these holes at the base, you can see some cells with low reflectance, and these are the retinal pigment epithelial cells. So these are found at the bottom of the macular holes, and the density of these are almost 4,000 to 6,000 per millimeter square, which is consistent with that found in the autopsied eyes. So almost near histology. Now there are also some hyper-reflective dots which are found here at the bottom of the hole, and this could probably be the outer segments which are released during the pathogenesis of the macular hole, which are released, and then they fall on the base of the RPE here. Now when you look at the follow-up of these patients, you can see how you can see the density of the cones increasing with hole closure. at 6 months, and this is almost a follow-up of 2 months. Dr. Mori from Japan, he was kind enough to share the images, and you can see how the cones are getting spaced out, and there's remodeling of the hole with spreading of the centripetal spread of the photoreceptors. This image shows the healing process of the traumatic macular hole with almost a 2-year, almost a 1-year follow-up, which is 52 or 51 weeks. And we usually assume that the remodeling stops, but you can see how the remodeling continues. We can see the OCT here with a small ISOS disruption here, and how the cones the density keeps increasing at the center and the spacing keeps increasing. So there's remodeling of the photoreceptors even up to a year after healing. Now, Dr. Rajiv Muni and his group from Toronto, they presented a poster where they looked at 9 eyes who had successful with idiopathic macular hole, and after successful closure of the macular hole. This is how the adaptive, this is the same RTX1 machine, which is a flood illuminated adaptive optics, and you have to superlay your images on your retri images. Here you can see post vitrectomy, the hole is closed. And there's remodeling. So they've looked at these 9 patients, and they've looked at the cone density, regularity, dispersion, and the spacing. And they at 2 degrees and 4 degrees eccentricity, they've said at 2 degrees there is a significant change with the cone density increasing, but at 4 degrees there was no statistical difference. Now, if you look at the photoreceptor disruption that our previous speakers, Dr. Chetan, has very well elucidated with his images. Here, this is a patient who has a better prognosis because of the intact ELM and the ISOS layers, whereas this patient, you can see there's some disruption here. There's some loss of the outer segments here, and at the end, there's a defect of the cone outer segment layers. So this group has looked at images of adaptive optics in these patients, and they've also used microperimetry to see the foveal sensitivity along with the structural and to look at the structure function correlation. And they found that those patients who did very well, who had intact outer segment, inner segment layers, as well as their cost layer, the cone outer segment tips, did significantly well with no absolute scotomas, but the ones who had a small defect had a small absolute scotoma. They found some dark areas also here. These dark areas, they found that it correlated preoperatively with the longer symptom duration, and postoperatively with low visual acuity, lower foveal sensitivity, thinner inner outer segment layers, and larger decreased reflectivity size. They also found that those who had these defects in the fluid cuff of the outer segments before surgery and these moderately reflective zones, these moderately reflective areas were basically the glial tissue, which is remodeled to close the hole. The same group went on to look at the cone ratio reflectivity, where they looked at this reflectivity. Those who had more than less than 2 standard deviation less in the reflectivity area within the foveal zone of about 350 microns, these are the green ones, and the red ones are outside this, where the reflectivity. So they actually quantified the reflectance of these cones, and they found that those who had ISOS disruption or these moderately reflective zones had had increased in the hyporeflective zones. There was more cone loss ratio, and even those in whom it closed but the cone outer segment disruption was seen, they also had a cone loss ratio. So they gave some prognostic factors where they said that the decreased reflectance ones had more dark areas, and this could also help in prognosticating our patients. We've looked at studies have looked at the human amniotic membrane plugs in failed macular hole closure, and also seen that there is photoreceptor, even beyond the plug, there is spread of the photoreceptors and there's remodeling, and that does help in visual information. We've looked at epiretinal membranes, and there are these microfolds which can help, which leads to metamorphopsia in these patients, and post vitrectomy you can see these microfolds disappearing. You can see they've classified the epiretinal membranes as radial, depending on the morphology, as well as grid kind of epiretinal membranes, and help decide which patients have more metamorphopsia and how it looks post-surgery. So basically, it helps us understand the pattern of foveal reconstruction in closed holes, which could be a balance between proliferation of glial cells as well as bridging of photoreceptor cell bodies. Can help us objectify these, quantify these, and help us associate with function, that's visual acuity and retinal sensitivity. We can monitor these patients, and we can even find novel biomarkers which would help us prognosticate the surgical outcome in these patients. Thank you very much for your kind attention.
Thank you, Dr. Supriya.